Let's talk about unstable angina. So here what we have is a 58-year-old hypertensive diabetic smoker presents with central squeezing chest pain radiating to left arm and jaw, occurring at rest for 3 hours, with similar episodes increasing over 10 days despite rest or nitrates. ECG, ST depression at V4 V6, T inversion, and troponins are negative. So, obviously, it is an unstable angina. Features are crescendo pattern at rest, ischemic ECG changes without ST elevation or troponin rise. Okay, let's talk about unstable angina. In unstable angina, it is a acute coronary syndrome without without myocardial infarction. What is the characteristics? Characteristics. What we have here? We have the most important is chest pain, means angina at rest. Okay, this chest pain doesn't resolve by rest or nitrates, not relieved by rest or nitrates. It lasts for 3 hours. This thing is called Levine test or Levine sign. Okay, next is stable angina with rapidly increasing pain, or it can be characterized as persistent chest pain after acute myocardial infarction despite adequate anti-angina ট্রিটমেন্ট অর থেরাপি, অর্থাৎ ওষুধ দেওয়া সত্ত্বেও যখন ব্যথা হচ্ছে মাইকার্ডিয়াল ইনফেকশনের পর। নাও what happens here? If it is my, we can make a picture. If it is my blood capillary, then here I have some tissue like this, like here I have a plaque, and over this thin I have a fibrous cap. So this deposition, and it is a fibrous cap. Now what are the investigations in this case? The first one is obviously ECG at rest or in between the attacks. ECG shows mostly normal. Okay, ST is depressed in 25% of cases. T wave in inversion in 25% of cases. Now, C troponin 1 is normal or elevated. C troponin 1 normal or elevated. Other than that, we can obviously do echocardiography, coronary angiography, for site and extent of coronary artery stenosis, and newer techniques like intravascular USG, intravascular ultrasound, CT, MRI, PET scan. Coronary angiography, PET scan. Next is the management. So we have 3 steps of management. First is general management. So explain the disease to patient, explain to patient, avoid aggravating factors like walking after meal, avoid exercise, avoid smoking, control the comorbidities like diabetes, hypertension, dyslipidemia, etc. Next is specific treatment. So now if I talk about the specific treatment, then we have ABE MON, that is ABC IXIMAB, beta blocker, metoprolol, and enoxaparin SC. It is morphine, O2, aspirin 75 as antiplatelet, and nitrates in TG drip. Okay, this is the drug of choice. Now how will I give it? Tab isosorbate mononitrate, 1 tab in the morning and evening. In case of acute pain, use glycyl trinitrate and sublingually to relieve the pain within 2-3 minutes. Once pain is relief, spit out the tablet. If there is contraindications of beta blocker and nitrates, beta blocker can be used. Antiplatelets like aspirin can be given, or clod clopidogrel can be given. Despite the above therapy, if angina is not controlled, add the ranolazine nicoradiol ifabratin. In spite of adequate medical therapy, if continual quality of life does not improve significantly, then surgical intervention like percutaneous transluminal coronary angioplasty. Okay, so the final way. So let's write the detailed we can use is tablet isosorbide mononitrate 20 milligram, obviously 1 BD, one in morning and evening. Next is for acute pain sublingual glyceryl trinitrate 500 is given within 2-3 minutes, then spit out after pain is gone. If nitrates are contraindicated, in that case then use metoprolol, that is a beta blocker, metoprolol 50 BD. Antiplatelet aspirin 75 or clopidogrel 75 for prevention of thrombus formation. Despite all, if not improve, give ranolazine, ivabratin, or nicoradiol. If not improve, then we will do PTCA, that is percutaneous transluminal coronary angioplasty, or CABG, that is coronary artery bypass grafting.